My presentation today is about the ileocecal valve, the appendix, and the large bowel. The ileocecal valve separates the terminal ileum from the cecum and prevent reflux from the cecum into the small intestine. Gross anatomy of the ileocecal valve. The ileocecal valve upper and lower lip that are covered by mucosa and protrude into the lumen of the cecum. This fold extended laterally as a frenulum. This formed the opening of the terminal ileum into the medial cecum and delineate the upper margin of the cecum from the ascending colon. This is a gross image showing us this is the terminal ileum and this is the cecum. This is the circular muscle of the terminal ileum extended laterally as the ileocecal valve. This is upper and lower lips of ileocecal valve, which extended laterally as the frenulum. The morphology of ileocecal valve has been described on endoscopy as 3 types. The most common type is the first type, labial type, slit-like opening, and papillary type, dome shape, and the last type is lipomatous type, where significant amount of fat demonstrated into the lips. Radiology of the ileocecal valve. We start by plain film of the abdomen. The usefulness of a plain film of the abdomen is in the bowel obstruction to differentiate between 2 types of bowel obstruction with competent valve and incompetent valve. Gaseous distension of the colon is seen proximal to the site of colonic obstruction. We have 2 types of colonic obstruction as we see here in this image. Type 1 with competent ileocecal valve and type 2 with incompetent ileocecal valve. In type 1, we see there is distension of the cecal only without excessive distension of a small or large bowel. In type 1b, there is distension of a small bowel in addition to the cecal distension. In type 2, we have competent ileocecal valve, so we have distension of a small and large bowel only without excessive dilatation of the cecum. This is a plain film showing us bowel obstruction with incompetent ileocecal valve. So we have distension of both the small and large bowel without excessive distension of the cecum. The second examination is barium examination. The ileocecal valve may present as filling defect in the posterior medial wall of the cecum, polypoid or bilabial, depending on the state of the contraction of the valve. We have 2 anatomical variants, lateral and posterior. Lateral about 7.5% and posterior about 5%. This is barium examination showing us this is the terminal ileum and this is the cecum. This is the ileocecal valve represented as filling defect in the posterior medial wall of the cecum. This is double contrast enema demonstrates a smooth elliptical lesion in the right side of the colon.
بس صوتك موجود الشورى.
اوكي دكتور يمكن النت هاي.
هو كان دا يتقطع عندي كمين الصوت بالبداية.
دكتور والله ما أعرف دكتور هاي على 4G.
شيري بابا رشا شيري بنت الدوج.
اوكي دكتور. Okay.
Hey, okay.
This is double contrast enema demonstrate a smooth elliptical lesion. Sorry. This is double contrast enema demonstrate a smooth elliptical lesion in the right side of the colon, represent the ileocecal valve. This is the ileocecal valve. And lastly, we have computed tomography. This is coronal CT of the right iliac fossa. This is showing us this is the cecum, and this is the terminal ileum. This is the ileocecal valve at the junction of the terminal ileum with the cecum. Our second subject is about the appendix. The appendix arises at the convergence of teniculi on the posterior medial wall of the cecum, about 2.5 cm below the ileocecal valve. This is the orifice of the appendix, and this is the ileocecal valve. The orifice of the appendix is about 2.5 cm below the ileocecal valve. It is variable in length between 12 and 24 cm and it is on mesentery, a triangular fold from the lower border of the ileum. This is the appendix of this is the the mesentery of the appendix, which extends from the lower border of the ileum. It is known as mesoappendix. As a result, the appendix is mobile. Blood supply of the appendix. The appendix is supplied by the appendicular artery, which is a branch of the ileocolic artery. The ileocolic artery itself is a branch from the superior mesenteric artery. The appendicular artery reaches the appendix through the mesoappendix. This is the mesoappendix. If infection causes thrombosis of this artery, gangrene and perforation of the appendix will occur. Lymphatic drainage of the appendix is through the appendicular lymph node to the paracolic node along the ileocolic lymph node, and then to the superior mesenteric artery group. Variation in position of the appendix. We have multiple variation in position of the appendix. The most common variation is the retrocecal. Here, the retrocecal location of the appendix about 64%. And then the inferior medial subcecal, which is about 35%, and post-ileal about 0.5%. Other location, pre-ileal, subileal, and pelvic. The location of the appendix has wide individual variability. It may be found in McBurney point or anywhere from the groin to the appendix. It can be also found high under the liver or in the midline, and very rarely in the left iliac fossa. Radiological feature of the appendix. We start by plain abdominal film. Fecalith or fluid level of the appendix may be visible on a plain film of the abdomen in the right iliac fossa in approximately 10% of the individual. This is a plain abdominal film showing us this is appendicolith in the right iliac fossa. Ultrasound. The appendix is identified as a blind end tube arising at the posterior aspect of the cecum. It shows no peristalsis and variable in position with a diameter of equal or less than 6 mm. On compression using the ultrasound probe is used to reduce obscuring gas in overlying bowel and to push overlying bowel loop out of the way. As we see here in this image, we do compression to see the normal appendix of a diameter of equal or less than 6 mm, and it shows no peristalsis. A recently described dynamic ultrasound technique using a sequential 3-step patient positioning protocol to increase visualization of the appendix. At first, we examine the patient in conventional supine position, then turn the patient 45-degree left posterior oblique, then look with the patient in supine position. CT scan of the appendix. As we say, the appendix arises from the posterior aspect of the cecum, inferior to the insertion of the terminal ileum. This is coronal CT of the right iliac fossa, showing us this is the appendix, arises from the posterior aspect of the cecum and inferior to the terminal ileum. Features of normal appendix. Normal caliber equal or less than 6 mm, preserve appendicular fat, intraluminal gas, or oral contrast. This is axial CT showing us the normal appendix, which is located behind the terminal ileum. It may be intra or retroperitoneal. The normal appendix containing gas and has thin wall and surrounding by homogeneous non-inflamed appendicular fat. This is another axial CT showing that the tip of the appendix, this is the tip of the appendix, lie lateral to the right lobe of the liver. This is coronal CT showing us the appendix also lie lateral to the left lobe of the liver. If appendicitis develop here, the point of maximal tenderness will be not here in the expected site in the right lower quadrant. Appendicitis is inflammation of vermiform appendix. It is a very common condition in general radiology practice, and it is one of the main reasons for abdominal surgery in young. Appendicitis is typically caused by obstruction of the appendiceal lumen. Obstruction may be caused by lymphoid hyperplasia is the most common cause, about 60%, appendicolith about 33%, and foreign body about 4%. Ultrasound criteria to diagnose appendicitis: blind-aid tubular structure at the point of maximum tenderness. It is non-compressible and peristaltic with a diameter of more than 6 mm and surrounding by echogenic inflammatory appendicular fat. The wall thickness almost equal or more than 3 mm. Appendicolith casting acoustic shadow. This is case of acute appendicitis showing us this is normal caliber appendix with narrow zone of transmission to the dilated inflamed appendix. Here we see fluid debris level. This is another case of acute appendicitis showing us this is dilated appendix surrounding by echogenic fat and increased vascularity of its wall and with appendicolith seen inside the appendix and nearby fluid collection. There are many complications of acute appendicitis. Appendiceal perforation is one of them, and it commonly occurs after gangrenous appendicitis. As we see here in this case, this is inflamed appendix. The wall is not seen here, and there is nearby fluid collection. Another complication is appendiceal mass phlegmon. This case showing us this is dilated appendix, and this is echogenic mass structure near adjacent to it with peristaltic terminal ileum and surrounding my echogenic fat. This is case of a phlegmon. The last complication is appendiceal abscess. This is part of the appendix, and there is nearby fluid collection and non-dependent echogenic foci. Here we see all this feature goes with appendiceal mass, appendiceal abscess. Sometimes ultrasound cannot be conclusive about the diagnosis of acute appendicitis. So CT will confirm the diagnosis of the appendicitis as we see here. This is inflamed appendix. The inflamed appendix show failure to fill with air or oral contrast and show enhancement of the wall and surrounding by inflammatory changes. Our last subject is about the large intestine. The large intestine is variable with average length of 1.5 meter and variable in diameter. Start by the cecum, ascending, hepatic flexure, transverse colon, splenic flexure, descending, sigmoid, and rectum, and lastly, the anal canal. The large bowel is marked by 3 flattened bands of longitudinal muscle called the tinea coli. The tinea coli are shorter than the colon for about 30 cm and cause formation of circulation which give rise to radiologically to the appearance of incomplete septa, the haustra. As we see here, the haustra is prominent in the ascending and transverse colon and tend to disappear distally. Peritoneal attachment of the large bowel. Ascending and descending colon are retroperitoneal, and the peritoneal space lateral to these are called the paracolic gutter. The cecum and transverse colon and the sigmoid colon, all of them are intraperitoneal. The transverse colon has its own mesentery, mesocolon, And the sigmoid colon also has its own mesentery. Splenic flexure attached to the diaphragm by phenocolic ligament. The rectum divided in three parts. The upper third covered anteriorly and laterally by the peritoneum, and middle third covered only anteriorly by the peritoneum. Lower third is free of the peritoneal attachment. This image showing us the peritoneal attachment. This is the lesser omentum between the stomach and the liver, and this is the greater omentum between the transverse colon and the stomach. The transverse colon, as we said, has its own mesentery known as transverse mesocolon. The sigmoid colon also has its own mesentery known as sigmoid mesocolon. And this is the mesoappendix. We also see here small bowel mesentery. Large bowel, blood supply, venous drainage, and lymphatic drainage. Blood supply of the large bowel is through superior and inferior mesenteric arteries. Superior mesenteric artery for part derived from the midgut, from the cecum to the mid-transverse colon. It has three branches: ileocolic artery, right colic artery, and middle colic artery. The ileocolic artery supplies the cecum, appendix, and beginning of the ascending colon. The right colic artery supplies the remainder by the transverse colon. The inferior mesenteric artery for part derived from the hindgut, a transverse colon to the upper rectum. It also has three branches. The left colic artery supplies the descending colon. The sigmoid artery supplies the sigmoid colon, and lastly, the superior rectal artery supplies the upper rectum. This image showing us the superior and inferior mesenteric arteries and their branches. The superior mesenteric artery first gives the middle colic artery, which supplies the transverse colon, and then they give the right colic artery, which supplies the ascending colon. And the ileocolic artery supplies the appendix, the cecum, and the beginning of the ascending colon. The inferior mesenteric artery on the left side give the first left colic artery supply the descending colon. Sigmoid arteries that supply the sigmoid, and lastly, the superior rectal artery which supply the upper rectum. Each of this branch anastomosis with neighboring branch through marginal artery of Drummond. The region of the colon between the supply of the superior and inferior mesenteric artery around the splenic flexure is known as watershed area. This is area. This area is more vulnerable to reduced blood flow during hypotensive episode, leading to ischemic damage. Venous drainage, the vein of the large bowel follow the branch of the arteries. As we see here, the right colic vein and the ileocolic vein will drain into the superior mesenteric vein. The left colic vein, the sigmoid vein, and the superior rectal vein drain into the inferior mesenteric vein. The inferior mesenteric vein lastly drain into the splenic vein. Then the splenic vein and superior mesenteric vein unite to drain into the portal vein. Lymphatic drainage. The lymphatic drainage of the ascending and the transverse colon is through the superior mesenteric node. The descending and sigmoid colon through the inferior mesenteric node. Most of these lymph nodes will pass into the intestinal lymph trunk and then into the cisterna chyli, where it is ultimately empties into the thoracic duct. This image showing lymphatic drainage of the large bowel, the ascending and transverse colon through the superior mesenteric node, the descending and sigmoid colon through the inferior mesenteric node. Both of them will be drained into the cisterna chyli and lastly into the thoracic duct. Radiology of the large bowel. Abdominal X-ray gas within the colon or outline the colon or part of it. The hostra are fixed anatomical structure in the proximal colon, but in the distal colon require active contraction for their formation. Hostra may be absent distal to the mid-transverse colon. This is adult supine AB radiograph showing us this is the ascending, this is the transverse colon, and this is the descending colon. Hostra are more prominent in the ascending and mid-transverse colon and tend to disappear distally. The upper limit of the normal diameter of the transverse colon on a plain film is up to 5.5 cm, and of the cecum, 9 cm. Beyond this limit, in the right clinical setting, there is risk of cecal perforation. Then we have air contrast barium enema examination. When the patient in a round position, barium bowling in the dependent portion of the transverse and sigmoid colon. While when the patient in supine position, barium bowl into the ascending and descending colon as well as the rectum. Sorry, it's the rectum. Colonic transverse folds are spaced further apart than those in the small intestine, as we see here. It is a useful marker in distinguish among bowel segment on a plain radiograph. This is axial CT showing us the colon lie in the periphery of the abdomen, while the small bowel lie in the center of the abdomen. This is MR enterography showing us this is the liver and this is the stomach. This is the hepatic flexure and splenic flexure. This is the ascending colon and this is the descending colon. Here we see this is the sigmoid and this is the gallbladder. Sorry, urinary bladder. This is the superior mesenteric vein unite with the splenic vein to form the portal vein. This is a superior mesenteric artery angiogram showing us the superior mesenteric artery and its branches. This is the superior mesenteric artery. This is jejunal branch and this is ileal branch. And this is the middle colic artery. This is the ileocolic and right colic artery. Number 6 is the ileocolic artery and number 7 is the right colic artery. As we see here, this is the terminal superior mesenteric artery. This is inferior mesenteric artery angiogram showing us this is the left colic artery, which is the first branch, and then this is the sigmoid arteries, and this is the superior rectal artery. Cheliditis syndrome is a rare condition where the transverse colon is mobile and may interpose itself between the liver and the right hemidiaphragm. This is the transverse colon interposition between the right hemidiaphragm and the liver, and it is occur in normal subject. Bowel obstruction is a common condition that present in our clinical practice. As we see here, the large colon is filled with gas and to the descending and sigmoid colon. And thank you.
عايشة تيدي.
Okay.
دكتورة رشا داخل.
نعم أستاذ. This is a conventional angiogram of inferior mesenteric artery. Number A, left colic artery, the first branch.
left colic هذا conventional هو DSA.
DSA.
DSA أستاذ.
DSA مو conventional إيه. Digital subtraction. إذن A left
colic artery.
دكتور محمد مهدي B.
نعم أستاذ. المارجنال ارتري.
marginal اللي هو المن supply with structure. marginal supply with structure دكتور محمد. splenic flexure. تسمعني؟
نعم نعم أستاذ.
اوكي زهراء سي. زهراء علي رشيد.
نعم دكتور. letter C, inferior mesenteric artery.
This is the inferior mesenteric artery. اللي هو عادة يغذي الليفت سايدد كولون، مو صحيح؟
نعم.
تشوفين الكاثيتر
أها.
سلكتيف مسويه وبالهذا. اوكي. بعد زهراء، دعاء، سعد.
نعم أستاذ. sigmoid
إيه.
artery. sigmoid artery.
This is the sigmoid artery. دكتورة كيزان. إي.
نعم أستاذ. superior rectal artery.
superior rectal artery. وهذا آخر واحد مو؟
أي نعم.
إيه. أوكي. عندك بعد أستاذ محمد، تفضل أستاذ محمد.
اي نعم استاذ العدو يعطي. هسه مريم خليل. مريم.
نعم أستاذ.
نمبر 1.
نمبر 1 ascending colon.
نعم. لارا نمبر 2.
نعم أستاذ. نمبر 2 السيكم.
نمبر 2 سيكم. زين. نمبر 3 عمر.
نعم أستاذ. Appendix.
نمبر 4 علي حسين.
نعم أستاذ. الإليوم.
ونمبر 5 حيدر كريم.
نعم أستاذ. النمبر 5 ileocecal valve.
ها هي خلصوا.
إيه بس أنت مختارة هاي الصورة كلش، هاي الصور